Dear colleagues, it's my pleasure. This is with you, Dr. Hani Arif. This is Dr. Hani Arif, the board member and the secretary of the MENASO. And we are very happy to announce the second wave of MENASO rounds. This is an educational program we started in the MENASO, and it's spreading the knowledge across the stroke, different areas of stroke, and we are very pleased today to have with us from Egypt very eminent speakers. They will present some cases and we will discuss on the board. Me, Hani Arif, the chair and head of neurology department at Ain Shams University, and also Dr. Hussam Salah. He's a professor of neurology, Qasr Al Aini University, and we are having today with us Dr. Asmaa Sabbah, assistant professor of neurology, Qasr Al Aini, Dr. Ahmed Al Basyouni, professor of neurology at Ain Shams University, and Dr. Tamer Roshdi, lecturer of Ain Shams University. Without further delay, I will let my colleague, Dr. Hussam Salah, to introduce Dr. Asmaa for the first presentation.
Our MENASO round. It will be my pleasure to introduce to you Dr. Asmaa Sabbah. She's assistant professor of neurology in Cairo University and had previous experience in stroke units in Cairo. She has been the administration of our stroke unit in Cairo University, and also she had a lot of experience in stroke management in UAE. We'll talk now.
Thank you, my dear Professor Dr. Hussam Salah, for giving me the chance to be here today. And thanks for Dr. Hani Arif, our eminent stroke professors in the whole MENA region. I'm very honored and very pleased to be here today. And thanks for all the attending colleagues. And I'd like to start my presentation soon. My topic today, and the title of the case I'm going to present, it's Acute Ischemic Stroke, Investigating Etiology Beyond the Existing Risk Factor. And as we go through the case, you'll be able to relate why I chose this title. I have my patient who is a 66-year-old female patient. She's known case of atrial fibrillation, hypertension, and dyslipidemia. She woke up from sleep, discovered by her daughter, aphasic and hemiparetic. Patient presented to the ER, and upon initial assessment, she had acute dense hemiplegia, expressive aphasia, right-sided facial weakness. Still, she can comprehend and obey orders. And her NIHSS was 17. She was last seen normal by her sons and daughter 23 hours before the onset of symptoms, and CT brain had an MCA infarction established with hypodensity occupying more than 1/3 of the cerebral hemisphere. Neither IVR TPA nor mechanical thrombectomy were attempted. So the patient was admitted to the ICU and started on the routine regular management of stroke, started on low-dose aspirin, prophylactic anticoagulation, PPI, monitoring of all of the conditions and of all of her blood sugar, and her condition was a stable state, obeying orders all through. And then on day 14, she was started on therapeutic dose of low molecular weight heparins together with oral warfarines, and our target INR was 2 to 3, because we attributed the stroke in our patients to her atrial fibrillation, and it was an embolic stroke that deserves an anticoagulation, so that was our target. And she was kept in the hospital till she can achieve therapeutic anticoagulation and INR target. So on day 22, the INR reached 3, and she was about to be discharged. However, on day 23, the patient conscious level started to deteriorate. She became stuporous, obtunded, and difficult to arouse. She had a Glasgow Coma scale of 9. eye-opening to pain, sounds as best verbal response, and localizing to pain. And this condition was also associated with low-grade fever of 38.4. So the first thing that came to our mind that our patient might have developed hemorrhagic transformation of her ischemic stroke because she was fully anticoagulated and she had a therapeutic INR of 3. But actually that was not the case. The follow-up CT was stationary, just stationary with no evidence of hemorrhagic transformation or manifestations of increased intracranial tension. Her blood chemistry, the complete PAT count, liver function test, and renal function test were unremarkable. She had a CRP of 10. ESR, the first hour was 90. Pan cultures came few days later, negative for any infection, and the chest X-ray was unremarkable. So we were still very confused, and we had to go for lumbar puncture and CSF analysis. The cells were just about 12 per millimeter, predominantly lymphocytes, and proteins were within normal range. The CSF sugar was within normal range. Cultures came negative, and herpes simplex virus PCR came negative. We also did an EEG for the patient, suspecting that this disturbed level of consciousness might be attributed to an ictal activity or epileptic activity. However, the EEG came negative for ictal or epileptiform discharges. We were very confused, and the patient conscious level was getting more and more, was deteriorating and getting bad. So, getting worse. But actually, 2 days later, on day 25, patient had tender, red, tense swelling in the left calf, and deep venous thrombosis was confirmed by the venous duplex, extensive one, involving the left popliteal and the left femoral veins. And to our great surprise, that by the time patient was diagnosed as having deep venous thrombosis, her INR came 3.5. Vasculitis profile was ordered for our 66-year-old female patient. And as you see, everything came just strongly positive. ANA with a titer of 180, anti-DNA antibodies, the anticardiolipin, IgM and IgG, and the lupus anticoagulant all just came positive. According to the European League Against Traumatism, on that checklist for systemic lupus diagnosis, for diagnosis you need to score 10. Our patient scored 18, and she was diagnosed as systemic lupus erythematosus. She was started on methylprednisolone IV for 5 days, after which the conscious level robustly improved back to obeying orders. And she was diagnosed as systemic lupus erythematosus and secondary antiphospholipid antibody syndrome, and co-management with rheumatology department was planned. This was rapid wrapping up of my case, and I come now to discussion of some points that I really wanted to find answers to. This is my agenda for 6 questions I tried to find answers to. And the first one is it really possible to first diagnose SLE and antiphospholipid antibody syndrome in elderly adults? When we searched the literature, we found that yes, the answer is yes. According to Chen and colleagues, they studied SLE in the elderly, and they had a population of 19 patients, and the age of onset of symptoms, the mean age was 70, and the mean age at diagnosis was almost 71. We also found plenty of evidence in the literature here. Ashur and colleagues also, they discussed the same issue, and they had a study population of 18 patients who were first diagnosed at a median age of 70 years. And SLE, the range of age was between, at the time of first SLE diagnosis, was between 66 and 78 years. I come to my next question. Was the MCA infarction in our patient attributed to SLE, or it was attributed to the pre-existing risk factors she already had? As you know, she has atrial fibrillation, she is hypertensive, and she's dyslipidemic, which actually can justify why an MCA infarction can happen. When I tried to find an answer to that question, I found that stroke in SLE patient, there is always a challenge of attribution. we have to distinguish whether really stroke in SLE patient happened out of an SLE activity or it is just unrelated. Because if it happened in relation to the SLE activity, this will be primary neuropsychiatric SLE. And for detection of this and for confirming that the stroke happened in relation to SLE, we have to look for other extra neurological disease activities involving other organs like nephritis, arthritis, serositis, skin rashes, and hematological abnormalities. And it's really quite common that stroke attributed to SLE happens early in the course of the disease and is often accompanied by evidence of disease activity in other organs. If it is related to the SLE activity, it can be related also to the antiphospholipid antibodies. And in this case, it can be associated with systemic lupus activity or not. And it remains that the gold standard of neuropsychiatric SLE, the physician judgment. Some of the risk factors that can help us know that the stroke in SLE patient is related to the disease activity is the prior major neuropsychiatric manifestations, generalized disease activity, and positivity of the antiphospholipid antibodies. Whereas on the other hand, if the stroke in SLE patient is not related to the disease, this usually occurs at later stages and they are caused by the traditional cardiovascular risk factors. I move to my next question. Why did our patient have obtunded level of consciousness on day 23? And to answer this question, I'll go through some basic knowledge and information. The American College of Rheumatology defined 19 neuropsychiatric syndromes in patients with SLE. 12 of them are related to the central nervous system and 7 are related to the peripheral nervous system. And these manifestations are further subdivided into diffuse and focal. The diffuse manifestations are usually attributed to an inflammatory process. And one of these diffuse manifestations is acute confusional state, which I attribute the deterioration in my patient's conscious level to. So the neuropsychiatric SLE manifestations and syndromes can be classified into diffuse, that has an inflammatory pathogenesis, and focal, which has thrombotic pathogenesis and is most probably, and in most of the cases, attributed to the presence of antiphospholipid antibodies. It's very important to distinguish the etiology, inflammatory or thrombotic, for the best management. And in some cases, the two processes can be operational in the same patient at the same time. And the next question is, why are SLE patient and antiphospholipid antibody syndrome patients are at increased risk of getting cerebrovascular disease? I will not go through a lot of pathogenesis details, but it's only the general idea that it's always have been thought that our CNS is immunoprivileged, having the blood-brain barrier that tightly regulates the passage of leukocytes and autoantibodies from the peripheral circulation into the CNS. And it is not only the blood-brain barrier that is the only perfused place within our skull, but also other possible sites are the meningeal barrier and the choroid plexus. And over the past 7 years, there has been recognition of 2 more fluid transport mechanisms within the central nervous system, which are the lymphatic circulatory system, as well as the intradural lymphatics. All these represent potential avenues for the passage and the transport of leukocytes and autoantibodies in and out of our central nervous system. And it can happen that leakage, and it happens that leakage of antibodies from the peripheral circulation into our CNS, which can result in the different neuropsychiatric manifestations in SLE. This table includes the most commonly encountered autoantibodies within the CSF and within the serum, the peripheral circulation, that are found in patients with neuropsychiatric SLE. The most commonly and frequently one that is associated with the development of cerebrovascular events and strokes is the antiphospholipid antibodies, including the anticardiolipin antibodies, the anti-beta-2 glycoprotein, and the lupus anticoagulant. How do they produce these thrombotic effects? The antiphospholipid antibodies activate endothelial cells, platelets, and monocytes, and they shed prothrombotic microparticles. They also accelerate atherosclerosis directly, which is an independent risk factor for the development of stroke. Those systemic lupus patients who are antiphospholipid antibody positive are twice more likely to develop the neuropsychiatric manifestations. And also, the antiphospholipid antibodies, through their thrombotic effect, they can produce disruption of the blood-brain barrier, facilitating and giving access to whatever autoantibodies from the peripheral circulation to invade the central nervous system and produce the whole spectrum of the neuropsychiatric SLE. My fifth question that I tried to answer is how to investigate a stroke in SLE patients. It's not very different from the way we investigate our stroke patients. But in case we have an SLE patient coming presenting with a stroke, we have to thoroughly and investigate and exhaust our investigations to detect extra CNS activity, to check the antiphospholipid antibody status, in addition to the assessment of the traditional cardiovascular risk factors that we do. We pay special attention in systemic lupus patients with a stroke. We pay special attention to the MRI and MRA for the possibility of detection of vasculitis, which is rarely, frankly, documented in patients with SLE. And we also should exhaust our investigation, the cardiac investigation, maybe for the possible detection of the peculiar type of endocarditis that develops in SLE patients, the Liebman-Sachs endocarditis. So it's not that different, but the only different thing from the routine stroke is assessment of extra CNS activities and the antiphospholipid antibody status. And the role for angiography and MRI and MRA is very important, as I mentioned, for detection of possibly vasculitis, which is, however, rare in the clinical practice. And my last question for today is treatment of SLE attributed to stroke different? And the answer is yes, it is very different. And it's really important to know how different it is. The treatment decisions an SLE patient presenting with a stroke should be based on, is a stroke really directly related to the disease, which is the challenge of attribution, and the coexisting antiphospholipid syndrome. In the acute setting and in the management of acute stroke, thrombolysis has been successfully done in lupus patients. And in the acute phase, the initial workup and management does not differ between SLE patients and the general population. The symptomatic treatment of a stroke and the whole thing we do is exactly the same in SLE stroke patients on two conditions. If we have no systemic lupus activity, and if we have no antiphospholipid antibodies, if they are negative, if these two conditions are achieved, this is the case in which the SLE stroke patient will be managed exactly the same way we manage our stroke patients. However, this is not the case, and this is not what happens in SLE patients, because 2/3 of strokes in lupus occurs in the setting of generalized disease activity, suggesting the role of systemic inflammation in the pathogenesis of CVE. So, in moderate cases, glucocorticoids with or without immunosuppressive therapy should be administered. And in refractory cases, we should use others like rituximab, IVIG, plasma exchange. All have been tried in lupus patients with strokes with various responses. I just would like to share one of the articles by Nikopoulos and colleagues who treated 60 patients. They treated 50 patients of SLE with a stroke. They mentioned that those 50 patients, 60% of them, which is 3 out of 50, the stroke occurred in the presence of generalized lupus activity. They treated 17 patients with cyclophosphamide and 7 patients with azathioprine, and 3 of their patients were sequentially managed with azathioprine, cyclophosphamide, and then rituximab. And all those stroke patients with SLE who received combined immunosuppression and antithrombotic treatment had favorable outcome at 6 months with no recurrence of stroke or cerebrovascular events at least for 3 years. It's a nice algorithm for management of stroke patient and SLE. So we have SLE patient with a stroke. The first thing to decide is the status of the antiphospholipid antibody positivity. In case the patient has secondary antiphospholipid antibody syndrome, they should be receiving vitamin K antagonist, and our target INR should be 3 to 4. If this is not achievable, and the patient only can achieve a target INR of 2 to 3, there has to be addition of a low dose of antiplatelet. So what if our SLE stroke patient is antiphospholipid antibody negative? In this condition, we'll have to do our challenge of attribution. Is it really attributed to SLE? If yes, in the presence of generalized disease activity, antiplatelets plus glucocorticoids with or without immunosuppressants. And if there is no generalized disease activity, antiplatelets only will be used. And of course, if the patient is antiphospholipid antibody negative and the stroke is not attributed to SLE activity, we'll just do our routine regular management of stroke. I would love to go through some of the guidelines for management of stroke in systemic lupus and antiphospholipid antibody. And we have the EULAR recommendations, the European League Against Rheumatism, for management of SLE. They recommended that in neuropsychiatric SLE, the management has to include glucocorticoids or immunosuppressives for manifestations that reflect an inflammatory process, and antiplatelet for atherothrombotic or anticoagulants for antiphospholipid antibody-related manifestations. That's for the SLE. They have other recommendations for the antiphospholipid antibody. For primary prophylaxis, for those patients who are only carriers of high-risk antiphospholipid antibody profile, they only have positive laboratory assessment and positive antibodies for the antiphospholipid syndrome. They never presented with a thrombotic event. In this case, they recommend that those patients should be prophylactically treated with low-dose aspirin. So what for the secondary prevention? What for the antiphospholipid antibody syndrome who developed an arterial thrombotic event or a cerebrovascular accident stroke, ischemic stroke? As I mentioned earlier, that there has to be a target INR and anticoagulation with vitamin K antagonist, and the target is 3 to 4. And if we target 2 to 3, there has to be addition of low-dose platelets together with the vitamin K antagonist. And another recommendation is that they recommended against the use of rivaroxaban. They did not recommend DUAX in patients with antiphospholipid antibody syndrome and arterial events due to the high risk of recurrent of thrombosis, of arterial thrombosis. And they have another recommendation for the secondary prevention. What happens if the patient develops failure of all these managements and he develops recurrent arterial thrombosis despite the adequate management? They recommend escalation. If the patient was on target INR of 2 to 3, so the target INR has to be increased to 3 to 4. If the patient did not have a low-dose antiplatelet, so a low-dose antiplatelet should be added, or the patient can be switched to low molecular weight heparins. That's the randomized control trials, the trial that was prematurely, it was in 2018, and it was prematurely terminated due to the high incidence of recurrent arterial thrombotic events in the rivaroxaban arm. From that came the recommendation of the EULAR. And I couldn't just finish my topic without going to the American Heart Association, American Stroke Association guidelines and about the antiphospholipid antibody syndrome. And this is the secondary prevention 2014 guidelines that patients with ischemic stroke or TIA who meet the criteria for antiphospholipid antibody syndrome, in whom anticoagulation is not begun, antiplatelet therapy is indicated. And I come to my conclusion and my last slide. Systemic lupus and antiphospholipid antibody syndrome can be diagnosed for first time in elderly adults. Physicians managing strokes and SLE patients, they face the challenge of attribution. And SLE-related strokes, treatment with glucocorticoids with or without immunosuppressive therapy must be considered. And last point is, in antiphospholipid antibody syndrome and stroke, treatment with DOACs is not recommended due to the high incidence of recurrence of arterial thrombotic events, especially with the triple antiphospholipid antibody positivity. And thank you so much for your kind attention.
Thank you, Dr. Asmaa, for this excellent presentation. And before taking the questions and moving to the next speaker, Dr. Ahmed Bassiouni, I will just raise one question. Of course, as you mentioned, it's a common association that systemic lupus can present or can be associated with a stroke. But in the elderly, how can you differentiate that this is not incidental? I mean, this is just a coincidence. You recommend specific investigations like inflammatory markers like CRP, C3, C4, or other inflammatory markers to differentiate whether this is a real activity of lupus or any radiological marker to make sure, especially that this will make a difference in the treatment.
Yes, thank you, dear Professor Dr. Hani. There is no specific surrogate marker for detection of the stroke. Is it really attributed to the lupus activity or not? But it's the general picture of the patient and the general clinical picture and the general laboratory the findings. To me, this patient actually just showed really unclear reasons for deterioration of the level of consciousness. You know, she developed a DVT while her INR was 3.5. So all these things they pointed and they helped us to know that this patient had an ongoing autoimmune activity. So there is no surrogate marker. It's only the gold standard is the clinical judgment.
Okay, so I will let my dear colleague, Dr. Hussam Salah, to take the rest of the questions from the Q&A box. I guess you answered already many of them, dear Dr. Hussam. Somebody is asking about if there is any specific CSF pattern. Okay, you can answer. There is no specific pattern.
There's no specific pattern. Maybe some elevation of the cell counts, and they can be predominantly lymphocytes. And maybe sometimes there is elevation of the CSF proteins.
And any radiological pattern in stroke with lupus? Specific pattern?
Nothing. All the patterns have been documented in stroke with lupus. Even the watershed infarctions have been documented in systemic lupus patients, and they were really attributed to the lupus activity itself. It has been the major territorial infarctions, the frontal cerebral infarctions, middle cerebral artery infarction, basal ganglia infarctions, lacunar infarctions, and there is a very nice systematic review about the MRI findings of strokes in SLE patient. No specific pattern. Everything exists with SLE patient, even the watershed infarctions.
Is hemorrhagic transformation of a stroke is a good sign?
I think to our practice, it's not a good sign. It adds to the manifestations of increased intracranial tension, and sometimes it can halt us from giving the proper management and the needed anticoagulation. Sometimes I think it's not a good sign.
Does dabigatran is contraindicated in antiphospholipid syndrome?
It should not be used. There is recommendation of the EULAR against the use of all DOACs. The one that was used in the clinical trial was the rivaroxaban. However, they give a recommendation for all DOACs.
If there is pregnancy and lactation, what would be your recommendation in such a situation?
If there is pregnancy and lactation, in case of pregnancy, methylprednisolone can be used safely during pregnancy. It's fine to use methylprednisolone if it happens and there is generalized lupus activity and the patient had the bad luck to get a stroke and SLE while pregnant, I don't know, but IV methylprednisolone can be used as an anti-inflammatory measure to suppress the lupus activity safely during pregnancy.
Can we do thrombectomy in such patients? Is there any?
Yes, definitely we can do thrombectomy in lupus patients. If all the required criteria, no contraindication for that, yes, it can be done. But our patient presented very late.
Okay, I guess for the sake of time, also we will be satisfied with this discussion. Probably, if we have time by the end, we can also answer some questions.